Okay, so a couple of quick notes about the Glasgow Coma Scale. Now, the GCS is an objective measure of the level of consciousness. It's supposed to be rapid and reliable and reproducible, and there shouldn't be any differences between users, although I put a question mark because in my experience sometimes there is a difference between users. Sometimes you'll see a patient whose GCS has been 13 out of 14 all the way up until 9 o'clock in the evening, and then at night time their GCS changes to 14 out of 15, and when maybe a different member of staff has come on and scored it a little differently. It's not supposed to be a difference between users. There's 3 domains that are used. The eyes scoring a minimum of 1 and a maximum of 4 out of 4. For verbal response, a minimum of 1 and a maximum of 5 out of 5, and for motor response, a minimum of 1 and a maximum of 6. So in total, you can have a maximum score of 15 and a minimum score of 3 out of 15. An easy way that I find to remember how many points are dedicated for eyes, for verbal response, for motor, I start at the top and work down. So I think where the patient's eyes are most superior, so that scores 4 points. The patient's mouth is below the eyes, that scores 5. The patient's arms, which are usually used to look at to score their motor response, are below the mouth. So starting at the top and working down, it's eyes, mouth, arms, or 4, 5, 6. That's how I remember. And here we are. You can look this up in any textbook online to tell you in more detail exactly how many points are scored. I think for the eye opening and for the verbal response, it's pretty simple. For the motor response, I think this is sometimes where there's a little bit of difference or between users, or a little bit of confusion sometimes with students. So 6 would be a normal response. Can you lift your right hand? Can you poke your tongue out? Can you lift your left foot? Number 6 is where the patient doesn't do anything when you ask them, but maybe you give them a trapezius squeeze and their arm comes up to where you are squeezing. They may not be able to lift it the whole way, they may be too weak for that, but you see their arms start to come up. Number 4, they withdraw from pain, so their arm would move away from where you're causing the pain. And number 3 and number 2 are decorticate and decerebrate posturing. So I'll show you what they look like. So if you do a sternal rub, in this patient here below in B, do a sternal rub and their arms come up in this posturing. You flex at the elbows, legs extended, feet plantar flexed. You will score them a 3 in the motor part of the GCS, and that's bad, obviously. If however you do a sternal rub and they do this, their arms extend at the elbow, okay, and their wrists flex, their legs extend, the feet plantar flex, this is worst. Okay, well, it's not worst because scoring 1, which is no response at all, is worst. But this is bad, and this is worst. Okay, and this scores 3, this scores a 2. So that's what you're looking for. The changes, when you do a sternal rub, they may not flex as much as this, they may not extend as much as that. Okay, but take the bed sheets off, expose your patient. You don't want to keep inflicting pain on your patients. Just do it once. But expose the patient so you can see they will start to move in this sort of posture, or they will start to flex their arms, flex their elbows, flex their wrists. They will start to do that. If they've still got the sheets over, you're not going to notice. Okay, so here is a list of the things that indicate a serious head injury, and therefore justify a CT head according to NICE guidelines. Now sometimes it can be difficult to get your scan accepted, whatever it is, your CT, your chest, abdo, pelvis, CT head. It can be difficult to get it accepted by the radiologist. However, with the NICE guidelines, all you have to do is say the patient had a GCS of less than 13 on first assessment. I would like a CT head to exclude an intracranial hemorrhage, and your scan will be accepted straight away because your radiologist really can't refuse this if it's according to NICE guidelines. So these indicate a serious head injury. So a GCS less than 13 on first assessment, GCS of less than 15 after 2 hours, that's 2 hours after the injury. If you suspect an open skull fracture, or there is a confirmed open skull fracture, you need a CT head. If you detect a haematoma, that's blood behind the tympanic membrane, you need a CT head. If you suspect a base of skull fracture, that's a CT head. If you see panda eyes, it's a CT head. If you see battle sign, it's a CT head. You get the point, I'm sure. Otorrhea, rhinorrhea, CT head. A post-traumatic seizure, CT head. More than one episode of vomiting, a CT head. And 30 minutes of amnesia before the impact, again, CT head. Now these are the indications for CT according to NICE for adults, okay? For children it's different, so you're allowed to vomit a bit more, okay, before you have a CT head, if it's a child, okay, but this is for adults here. So, you're in A&E, you have someone who's had a car accident, not been wearing a seatbelt, hit their head on the dashboard. You have a look inside the ear, and this is what you find. This here is a haematoma, and what you are seeing here is a level of blood behind the tympanic membrane, indicates a base of skull fracture. This patient gets a CT head. What you're seeing here is panda eyes, or bilateral orbital ecchymosis, so there's bruising around both orbits, okay? This patient gets a CT head. This here, bruising behind the ear over the mastoid process, this is battle sign. This indicates also a base of skull fracture. This patient gets a CT head. And this patient is showing rhinorrhea. There may be otorrhea as well, but I haven't got a picture of this clear fluid draining from the ears, but you may look for that. This patient gets a CT head. Okay, this is CSF leaking from the nose, indicates a base of skull fracture. Okay, let's look briefly at brain herniation syndromes.